Aging, Changes, and Considerations, Part 2, an online education course presented by Care and Compliance. Part 2, Introduction. This is Part 2 of the course on Aging, Changes, and Considerations. In Part 1, we discussed how we age and the myths and facts about aging. We also discussed the changes that occur with aging in 5 of the major systems. In this module, Part 2, we will discuss the changes that occur with aging in 5 additional major body systems. Video content. This course contains information in several short videos. The content contained in the videos is in addition to the written text. It is strongly recommended that you have speakers on when viewing the videos. The text in this course is also narrated. You will need to have your speakers on if you wish to hear the narrator read and comment on the text material. Body system changes as we age, sensory system. Our sensory system is the part of the nervous system responsible for processing sensory information. Our sensory system allows us to receive information from our environment through our eyes or vision, our ears or hearing, our skin or touch, our tongue or taste, and nose or smell. Our sensory system provides us with a great deal of information about our immediate environment so we know how to react and respond. For example, think how you feel and act when you smell the sweet smell of a puppy's breath. In contrast, how you feel and act when you smell the smoke of a house fire or scent of spoiled food. Sensory loss. Sensory loss is defined as a decreased ability to respond to stimuli that affects our senses. Losses of a resident's ability to enjoy his or her environment through the senses can lead to social isolation, loneliness, and feelings of depression. Age-related changes. Sensory changes occur differently for everyone in both the age of onset and the degree of loss. In general, the following sensory losses accelerate at these approximate age ranges: hearing in the mid-40s, vision the mid-50s, touch the mid-50s, taste the mid-60s, and smell the mid-70s. Hearing loss. Hearing loss is one of the most common conditions affecting older adults. Hearing loss often develops slowly and quietly. 25 to 40% of Americans over 65 years and 47% of those 75 and older have a hearing loss. And this diagram shows you 2 types of hearing aids. Hearing loss may be caused by any or all of the following changes that occurs with age: changes in the auditory nerve, a decrease in the elasticity of the eardrum, atrophy or shrinking of the eardrums, a drop in the number and activity of wax glands, which causes a decrease in wax secretion and the earwax becomes drier. This drier wax can more easily become impacted, block the ear canal, and reduce the ability to hear. The loss that occur with age often causes a decrease in the ability to hear high frequencies, more difficulty hearing in environments that are noisy, and a decrease in hearing certain sounds. 30 to 50% of older adults suffer a hearing loss serious enough to negatively affect the quality of communication and interpersonal relationships. Hearing loss can affect a person's life since he or she may miss out on talks with friends and family, have difficulty understanding telephone conversations, or be unable to follow a conversation at the dinner table or in a restaurant, or miss important information stated in a noisy environment. Sometimes hearing problems can make a person feel embarrassed and withdraw from participating in a conversation. It's also easy for friends and family to think the person is confused, uncaring, or difficult, when the problem may be that he or she just can't hear well. Care tips: hearing loss. Be aware that high pitches may be difficult to hear, so speak in a lower normal tone. Minimize background noise. Speak in front of the person so he or she can see your lips and facial expressions. Schedule regular hearing visits if earwax buildup is a problem, and encourage the use of a properly fitted hearing aid if needed.
This is what you can do for a resident that has a hearing impairment. First of all, sit in front of the resident or stand in front of the resident if you are going to be speaking to them so they have a clear view of your face. Do your best to avoid background noises. Turn the television down. Take the resident to a quiet area if you need to have a lengthy conversation. Assist the resident with their hearing devices. Many residents will wear hearing aids. You will want to familiarize yourself with the manufacturer's instruction for their care and operation so that you can help the resident with their hearing aid. Every morning, remind or assist the resident to place their hearing aid. Make sure that it's adjusted to the proper level. In the evening, you will want to help them remove that hearing aid. Oftentimes, a hearing aid must have the battery removed at night. Be cautious of the pitch in the tone of your voice. Make sure that you are not speaking in too high of a tone because that's harder for the resident to understand. Use a lower, natural tone voice. When assisting the resident that has a hearing loss, it may be necessary to encourage others around to use a proper tone of voice at the appropriate level as well. For example, if you are going to seat a resident next to another resident that they are just meeting for the first time, you may want to encourage that other resident to speak in a tone that the resident can hear. Additionally, monitor the resident for increased hearing loss. This could be an indicator their hearing aid is not working properly, or if they do not use a hearing aid, it could be an indicator that it is time for them to be reevaluated. How would you know your resident's not hearing well or their hearing loss is increasing? Some of the ways you'll know is that a resident will ask you to repeat things frequently. You may see them actually cup their hand behind their ear and lean forward so that they can hear you. You may also find that a resident begins to isolate themselves. They don't participate in group activities like they once did simply because they're embarrassed that they can't hear and participate easily. You may also find that a resident becomes a little more cranky simply because they're having a hard time understanding you or they may misunderstand what you're saying. When caring for our residents, we must never clean the inside of the ear canal, only the external ear. Never place a Q-tip or other device down inside the resident's ear. You heard it discussed earlier that as people age, there can be a buildup of cerumen, also known as earwax. That is only for the professional to remove. So if you notice your residents having increasing difficulty in hearing, you may help them schedule an appointment with their medical professional, but never cleanse the inside of the ear canal.
Vision loss. Most people experience some decline in vision as they age. Vision changes. Some of the normal changes that older adults experience with vision include reduced ability of the lens to accommodate. Reading glasses may be needed around age 40 or older. A yellowing of the lens, so more light is required. Reduced speed in adapting to changes in light and dark. Problems with color discrimination. Increased number of floaters. Eye floaters look like black or gray specks, strings, or cobwebs that drift inside the eye. Most eye floaters occur when microscopic fibers within the eye clump together and cast tiny shadows on the retina in the back of the eye. Other vision changes that occur with aging are pupils that become smaller and less responsive to light. This causes decreased vision at night or in dark rooms. Eyeglasses may also cause difficulty seeing green and blue colors due to the lenses. Drier eyes from less tear secretion, resulting in less protection. Eyes are easily irritated by dust and air pollutants. Common diseases. Vision loss that is severe enough to impede performance of everyday tasks is considered low vision. Most older adults with low vision will have one of four conditions. Number 1, macular degeneration. Number 2, glaucoma. 3, cataracts. Or number 4, diabetic retinopathy. Macular degeneration. Age-related macular degeneration is the leading cause of vision loss for people over 50 in the United States. Macular degeneration is caused by a progressive, irreversible damage to the macula, a part of the retina. The most common signs and symptoms are vision loss in the center of the eye. The picture to the right shows what this vision loss might look like. Blurred vision, straight lines that look wavy, a need for more light. Glaucoma. Glaucoma is the leading cause of blindness in the United States. It is due to internal damage to the optic nerve, usually caused by increased pressure within the eye. The most common signs and symptoms are a gradual loss of peripheral vision, and the picture to the right shows what this might look like. Difficulty driving at night, loss of contrast. Cataracts. A cataract is the clouding of the normally clear lens of the eye. The most common signs and symptoms are hazy vision, as you'll see in the picture on this slide, difficulty driving at night, double vision, trouble distinguishing colors, and sensitivity to glare. Diabetic retinopathy. Diabetic retinopathy can occur in people with diabetes and is caused by leaking blood vessels. The most common signs and symptoms are floaters, blurred or changing vision, and you'll see how this might look in the example on the slide, and difficulty reading. Diabetic retinopathy can affect central or peripheral vision. No matter the cause, low vision creates problems for the elderly, including increased risk of falls and fractures, difficulty identifying medications, which can lead to drug-related errors, loss of autonomy due to an inability to continue to drive a car, shop, or travel alone, loss of privacy, especially if others need to open and read the mail to a person, embarrassment, such as needing to use a magnifying glass to read a menu in a restaurant, or inability to recognize the face of a familiar visitor.
Caring for our residents, we always want to make sure there is adequate lighting at all times in the facility. Even during daytime hours, it will be necessary to have lights on, especially if the resident is choosing to read or perform a close task. Remember, residents sometimes have trouble adjusting to a change in the intensity of light. So if a resident is going, for example, from a very bright room to a darker room, or for example, going from indoors to out of doors, we will want to encourage them to pause for a moment and let their eyes adjust to the different light level. Make sure that your activity and reading materials are in large enough print. In addition to large print books, you can purchase playing cards that have very large numbers on them, easy for the resident to see. It's not much fun participating in an activity if you're struggling just to see what's going on. Remind the resident to wear their glasses. In the morning, if they wear glasses at all times, encourage them to put their glasses on as soon as they awaken. In the evening, when you help a resident into bed, make sure their glasses are within easy reach. And by the way, make sure those glasses are clean. Sometimes our residents do not realize when the lens is becoming dirty, so we want to make sure those glasses are nice and clean. Use contrasting colors whenever possible. For example, a bright blue soap dispenser shows up much easier on a white bathroom sink than a soap dispenser of the same color. Dishware, make sure that it contrasts to the tablecloth or placemats that you might be using so the residents can see easily. If a resident has very significant deficiencies, you may want to contact your local Braille Institute in your area to learn even more tips. For example, at mealtime, if a resident has a very difficult time seeing, you may think of the plate like a clock and explain to the resident where the various foods are at. For example, you would let the resident know your Salisbury steak is at 6 o'clock, your peas are at 12 noon, and your mashed potatoes are at 3 o'clock. Additionally, never rearrange furniture without advising and teaching the new furniture arrangement to the resident, or this could pose a safety risk.
Touch. The sense of touch may be the most important of the senses. The skin is the largest organ of the body and has millions of nerve endings. People thrive on stimulation through touch. Without it, humans often feel a longing or aching. Examples of nurturing touch includes the warmth of a pet resting in one's lap, or a hand placed on someone's arm for reassurance, the feel of someone brushing his or her hair, a hug, the hand of a grandchild. As a person ages, the sense of touch decreases because the skin's sensitivity decreases. Touch is necessary for the basics of feeling temperature, such as putting on a sweater when cold, movement, or the pain of an injury. Risk of injury, such as burns or frostbite, can occur with inability to distinguish warm from hot or cool from cold. Small motor skills may also be affected with the loss of touch, such as picking up a coin, a sweater, or writing with a pen. Taste. The ability to taste also decreases with age. At age 30, a person has 245 taste buds on the tongue. By age 70, the number decreases to approximately 88. Older persons also have less saliva, and saliva is needed in order to taste. The normal seasoning in foods may seem bland, lack taste appeal, and discourage the older adult from eating. Sweet and salty taste are the first affected. This loss can cause older adults to eat excessive amounts of salt and sugar. The diagram of the tongue in this slide shows the order that taste is typically lost, starting with sweet, then salty, followed by bitter and sour taste. Care tips: loss of taste. Help residents keep their appetites by ensuring that food tastes good to them and is served in an appealing manner. Be aware that loss of taste senses may cause residents to complain that food has no taste or to seek more salt or sugar. Salt substitutes may be helpful for some residents. Smell. Smell makes things enjoyable. Our odor memories frequently have strong emotional qualities and are associated with the good or bad experience in which they occurred, such as taking time to smell the flowers, the smell of fresh bread baking, the perfume or cologne on a special person. Humans can recognize as many as 10,000 different scents compared to the sense of taste, which is limited to 4 basic categories: sweet, salty, sour, and bitter. The senses of taste and smell are intertwined to allow the appreciation of good smells and taste. Since the loss of smell also impacts the sense of taste, a loss of smell can also make food seem bland. If you've never done it, hold your nose while eating a familiar food. How does the taste change? The loss of smell can create social problems, such as a lack of awareness of poor personal hygiene. Nearly half of individuals 65 to 80 years old experience a loss of smell, and nearly 3/4 of those over the age of 80 experience such loss. The loss of smell can also be due to upper respiratory infections, head trauma or sinus problems, tobacco smoke, exposure to toxic agents such as workplace chemicals, or other causes that damage the olfactory nerves in the nose. The diagram to the left shows the location of these olfactory nerves inside the nose. Here's an interesting tip. In the case of Alzheimer's disease and Parkinson's disease, smell loss appears to be the first clinical sign of the disorders, occurring long before the cardinal signs of the syndromes. Care tips: loss of smell. Be sure to serve foods that look appealing. Color and texture can help compensate for the sensory losses of taste and smell. Body system changes as we age. Digestive system. Our body needs food for energy. Digestion is the process of breaking down foods into small enough components so it can be absorbed by the bloodstream. The digestive system is made up of the digestive tract, a series of hollow organs joined in a long, twisting tube from the mouth to the anus, and other organs that help the body break down and absorb the nutrients in food. The digestion of food begins in our mouth when we chew food into smaller pieces and mixing with saliva. Additional digestion occurs in the stomach and intestines. Juices from other digestive organs mix with the food to help break it down for absorption. Finally, the waste products are eliminated in the stool. This slide has a diagram of the organs of the digestive system. Age-related changes. The digestive process becomes less efficient as a resident ages. This means that even if the food is healthy and packed with nutrients, the resident may not be getting as much of what he or she needs, even with a good diet. More specifically, below are some of the digestive changes that occur with aging. Loss of teeth and ill-fitting dentures can make chewing more difficult. Decreased saliva production by glands. Difficulty swallowing, known as dysphagia. Decreased appetite due to dull senses of taste and smell. Decreased secretion of digestive juices, so digesting fried and fatty foods is especially difficult. Increased indigestion. Decreased peristalsis in the intestines. Peristalsis is a series of muscle contractions that moves the food through the digestive tract. Decreased peristalsis can cause more gas and constipation. Care tips help for digestion. Help residents choose a diet best for their needs. Avoid dry, fried, and fatty foods. Monitor the resident's ability to chew high-fiber foods. Assist residents to maintain good oral hygiene and denture care. If a resident has teeth or denture problems or has difficulty swallowing, his or her food could be pureed or ground. Make sure the resident maintains an adequate intake of fluids and adjust their caloric intake to maintain proper weight, always following physician's orders. Common diseases or disorders. Some common diseases or disorders of the digestive system include stomach ulcers, indigestion, constipation, hemorrhoids, diarrhea, cirrhosis of the liver, gastroesophageal reflux disease or GERD, and irritable bowel syndrome or IBS.
Just like the beginning of the digestive process begins at the mouth, we want to think about good oral care for our residents. Encourage them to practice good oral hygiene. Assist when necessary. If a resident wears dentures and suddenly there's a change in their food consumption, you always want to think first, could there be a problem with the fit of the dentures? Dentures that do not fit properly can make eating very painful for the resident. Additionally, we want to monitor the resident's food consumption and report to the physician if you notice any significant change. If you're caring for a resident and you are trying to encourage adequate nutrition, but the resident just doesn't have much of an appetite, there are some things that we can do. For example, make sure that there are no unpleasant odors in the dining area. Make sure you haven't recently cleaned the dining area with chemicals that might have an odor to them that is not pleasant. If you have incontinent residents, make sure that their briefs are changed every time prior to coming to the dining room. You will want to make sure that the portions you serve are not overwhelming. Sometimes serving a large plate heaped with food can actually make the resident feel nauseous and not like eating at all. It's just overwhelming. Serve very small portions that the resident can feel successful in being able to complete those portions. Make sure the resident has the right table mates. Being seated with friendly people at mealtime can make a difference in how much we choose we want to eat. Additionally, serve foods that the resident enjoys and can easily consume. If bowel habits are a concern, report any significant changes to the resident's physician. However, some of our residents actually worry excessively about their bowel patterns. A bowel movement anywhere from 3 times a day to just 3 times a week can be within a normal range. So know what is normal for your residents so you know when to report something abnormal. If you're caring for residents with significant memory loss, it may be necessary to actually write down or chart the amount and frequency of their bowel movements so you can keep a close eye on that. If a resident has trouble with constipation, make sure you're following the physician's orders that may include things like encouraging adequate nutrition, making sure the resident is drinking enough fluids, making sure they're eating enough fresh fruits and vegetables and have enough dietary bulk in their diet. Activity also helps with constipation. Just encouraging a resident to take a walk a couple of times a day can be very helpful.
Body system changes as we age. Respiratory system. The respiratory system consists of the lungs and muscles that support our ability to breathe. You'll note this diagram also shows the trachea or windpipe along with the lungs and the bronchus. Age-related changes. With aging, 4 characteristic changes occur in the respiratory system. Number 1, there's a decline in elasticity of the bony thorax around the lungs, causing a stiffer chest wall. Secondly, there's weaker respiratory muscles. Third, there's a decrease in the surface area on the inside of the lungs to take in oxygen. And 4, a decrease in central nervous system responsiveness. As a result of these changes with aging, residents may have difficulty breathing, known as dyspnea, and decreased strength for coughing. A resident may not have enough strength to cough and clear the upper airway of secretions. This can increase the risk of respiratory infections and diseases. Care tips help for breathing. If a resident has breathing difficulties, don't place heavy bed linens on the resident's chest because this can place additional stress on chest expansion. If a resident is bedridden, turning, repositioning, and helping the resident take deep breaths can help prevent respiratory complications. Encourage the resident to be as active as possible. Residents with respiratory problems such as chronic obstructive pulmonary disease, or COPD, may prefer a cooler room temperature or to have a fan flowing. Encourage activity as tolerated and recommended by the physician. Common diseases. Some common diseases of the respiratory system include chronic obstructive pulmonary disease, or COPD, which includes chronic bronchitis and emphysema, asthma, common cold, influenza or the flu, pneumonia, and lung cancer.
In order to maintain good respiratory health for our residents, much will be dependent upon their diagnosis. But even with healthy seniors, we want to encourage regular exercise unless contraindicated by their physician and deep breathing. We want to make sure that our residents are monitored closely for any signs or symptoms of respiratory infection. Now, this may be something very obvious, like a significant increase in body temperature, fever, a cough, increase in mucus or sputum. However, sometimes respiratory infections are very subtle in seniors. You may simply just notice that they're not quite eating like they used to, or that they're a little more short of breath than normal, or just sometimes just a little more tired. So again, we want to get them evaluated when we notice any significant change.
Body system changes as we age. Urinary system. The urinary system is the organ system that allows us to excrete waste from our body in the form of urine. The urinary system consists of 2 kidneys, 2 ureters, the bladder, and the urethra. And you'll see these components shown on the diagram on this slide. Age-related changes. Like most other systems, the urinary system also experiences a decrease in function with age. Specifically, the following may occur. Kidney function is decreased. Blood flow to the kidneys is reduced. Kidneys atrophy or shrink, which can cause poisonous substances to build up in the blood and cause serious health problems. Urine becomes concentrated, especially if residents do not intake enough fluids. Bladder muscles weaken and hold less urine, and urinary incontinence may occur. Some common diseases of the urinary system include urinary tract infections or UTIs, urinary incontinence, kidney stones, and kidney failure.
The urinary system is the part of the body that's responsible for creating and voiding urine. This system includes the kidneys, the bladder, and the urinary tract. Like many other systems of the body, the urinary system also may experience age-related changes. These changes include a decrease in blood flow to the kidneys, a decrease in the filtering ability of the kidneys. We may see weakening of pelvic floor muscles. These are the muscles involved in us to control urine output. We may also see changes such as a decrease in bladder capacity and changes in the muscular wall of the bladder itself. Again, these changes can contribute to negative functional consequences. Negative functional consequences that include Nocturia, which means an increase in or a frequency of having to urinate at night. The person may experience chronic residual urine, which means holding some urine in the bladder even after going to the bathroom, and this can certainly contribute to things like bladder infections.
When my residents have had bladder infections, usually they let you know by asking to go to the bathroom more frequently than they normally do. Sometimes you'll notice them touching their private parts. Many times you can see more physical activity with maybe up and down out of their chair a little bit, wiggling around more than you've seen them do before. And sometimes they'll often tell you that, yes, I have pain when I'm going to the bathroom. Burning sensation, just doesn't feel the same.
The older adult may also have difficulty with certain medications that have to be removed from the body in our urine. Additionally, the older adult may experience urgency and frequency of urination. They'll notice changes compared to perhaps when they were younger, where they're having to go to the bathroom more often and more frequently.
Good urinary health can be maintained for our residents by encouraging them to toilet often enough so that the bladder does not retain urine for an excessive amount of time. We want the resident to consume adequate amounts of water unless contraindicated by their physician orders. Some of our residents will suffer with incontinency. There are many different types of incontinency, and our approach for caring for the resident will depend upon the type of incontinence that they have. Incontinent residents will have a service plan that indicates the type of care they need, so you'll want to review this. Some general principles related to the types of incontinency are as follows. Number one, stress incontinence. This is the incontinence where you see when a resident sneezes or coughs, they may lose control of their bladder and leak urine.
It can happen when they're coughing, when they're laughing, just even getting up and down out of the chair sometimes will create incontinence for them.
This is very, very embarrassing for our residents. Sometimes just laughing will cause them to leak urine. These residents will benefit by appropriate toileting often enough so the bladder does not become overfull. Additionally, the resident may choose to wear a small pad or brief just in case leakage occurs. They may be instructed to do special exercises by their physician. If so, you will want to remind them to do those exercises exactly as prescribed. Occasionally, you may have a resident with a neurogenic bladder. This is where the bladder is not emptying properly. Now, this most often is a result of a spinal cord injury, but could take place, for example, in someone who has had a stroke. Residents will be encouraged to void, and they may even be ordered by their physician to put a small amount of pressure over the bladder when voiding. Once in a while, these residents may require the use of a catheter as well. Urge incontinence may take place due to a variety of irritations to the bladder, anything from a bladder infection to sometimes even the food or beverages that we consume. Encourage the resident to void at regular intervals. Oftentimes, the physician will ask you to escort the resident to the bathroom at least every hour. You will encourage the resident to wear clothing that can be quickly removed and easily removed should they need to toilet quickly. Additionally, with urge incontinence, you may be encouraged to make some dietary changes, such as decreasing the amount of caffeine the resident may consume, or decreasing the amount of high salt foods, or increasing the amount of water the resident should consume. With urge incontinence, it may assist the resident even to void during the night. The resident may choose to set an alarm so that they awaken and void on their own during the night.
It's helpful to have a urinal for a male resident at the bedside so that he's able to reach it and use it during the night. Bedside commodes are often helpful. You don't want to always jump to using a diaper just because someone's incontinent.
Perhaps the most common type of incontinence you will deal with as a caregiver is functional incontinence. This is where the resident's body is performing just fine, but there are environmental reasons that the resident is not toileting appropriately. One reason, frankly, can be embarrassment.
They'll sometimes be very embarrassed, don't want to talk about it. Others will let you know right away. Those that are embarrassed about it will hide their underwear, not want to be around people as they normally would, step back sometimes as you approach them because they're aware of the odor oftentimes.
With confused residents, it may be they simply can't find the bathroom. They're not sure where it is. You may sometimes find they void inappropriately, for example, using trash cans instead of the toilet. One way to easily handle this is to remove anything that might look or they could think of to use as a toilet. Clearly light the way to the bathroom so they can easily see where the bathroom is at. Putting labels and directions to the bathroom, and not just saying bathroom with an arrow, but perhaps a picture of a toilet is easier for the resident to follow. When a resident is new to the facility, don't just say, to go to the bathroom, you go down the hall and turn to the right. Walk with the resident to the bathroom. Show them the exact way how to get there. Show them how to turn the light on and off, where the towels are, soap, etc., so they feel very comfortable using the bathroom.
Care tips help with the urinary system. Make sure that the residents drink adequate amounts of fluids to avoid urinary tract infections. Fluids include water, fruit juices, milk, and gelatin. Remind residents to drink and make sure fluids are available to them. Encourage fluids before 5 p.m. to help avoid urination at night. Now, this does not mean that we would withhold fluids if the resident needed something to drink later than 5 p.m. Follow bladder training programs to help those with urinary incontinence. This might include as a direct staff member that you're reminding them to use the bathroom at scheduled times. And always monitor residents for any signs of a urinary tract infection known as a UTI. Body system changes as we age. Integumentary system. The integumentary system is the largest organ system of the body and includes the skin, hair, and nails. The integumentary system is the organ system that protects the body from damage. It functions to waterproof our body, cushion and protect the deeper tissues, regulate temperature, detect pain, sensation, pressure, and temperature. Skin. The skin does many things. It protects us from the environment, helps regulate the body temperature, helps with fluid and electrolyte balance, and provides receptors for sensations such as touch, pain, and pressure. Skin changes are among the most visible signs of aging as our skin begins to wrinkle and sag. With aging, the outer skin layer, called the epidermis, thins even though the number of cell layers remains unchanged. The fat layer under the skin, or the subcutaneous layer, which provides insulation and padding, also thins. This increases the risk of skin injury and reduces the ability to maintain body temperature. With less natural insulation, hypothermia, meaning cold body temperature, can result more easily in cold weather. Because of the skin and fat layer thinning, aging skin appears thinner, more pale, and translucent. Changes in the connective tissues reduce the skin's strength and elasticity. This is especially pronounced in sun-exposed areas and produces the leathery, weather-beaten appearance common to farmers, sailors, and others who spend a large amount of time outdoors. The blood vessels in the skin become more fragile, which can cause a resident to bleed or bruise more easily. Sebaceous glands produce less oil as a person ages. Men experience a minimal decrease, usually after the age of 80. Women gradually produce less oil beginning after menopause. This can make it harder to keep the skin moist, resulting in dryness and itchiness. And this diagram shows an enlarged cut section of skin, showing the pore, which consists of the hair follicle and the sebaceous gland. The sweat glands produce less sweat. This makes it harder to keep cool, and a resident is at increased risk for becoming overheated or developing heat stroke. Growths such as skin tags, warts, large pigmented spots called age spots, liver spots, or lentigos, and other blemishes are more common in older people. Some common diseases of the skin include skin cancer, dermatitis, psoriasis, and rashes.
The skin is the largest organ of the body and serves a very important purpose in that it protects the body against infection. While many of your residents will be able to take care of their skin on their own, some will require your assistance. First and foremost, keep that skin clean. You'll do this through regular bathing and hygiene. Make sure the skin is well moisturized and doesn't dry out excessively. Prevent chafing. If the resident is incontinent and wears adult briefs, make sure they are changed at least every 2 hours.
I like to change them every 2 hours, or when they request it, or when I just feel that I can smell something or they're looking or acting uncomfortable.
And in the process, they get good perineal care, which will include cleansing the entire area and rinsing and patting dry. Encourage mobility and movement. Oftentimes, we worry about the resident who is in bed all the time that they might end up with a bed sore, but frankly, any of our residents could possibly have skin breakdown. The resident that sits all day in one position, the resident in a wheelchair, the resident that rests on their heels with their feet straight out all the time can have a problem. So we want to make sure that we are keeping all of the skin areas appropriately protected. We can monitor our resident's skin while doing our daily activities, assisting the resident to bathe or dress or toileting the resident.
I look at it when I dress them, toilet them, shoes and socks. I like to look at their heels and their toes quite a bit too, because that's one of the places that residents can really get into some problems.
Take that few moments extra to monitor for any change in skin status.
Sometimes I get so busy I have to get residents down to the dining room, have to toilet somebody. It's hard to always make sure that I'm looking at residents' skin, but I make sure that when I am toileting them, I'm looking at their skin around their private area and on their back. I like to look at their feet if it's possible, their heels and their toes as well. It's not easy to fit in, but I do my best.
Our big concern is a little small rash or reddened area can quickly turn into serious trouble for a resident.
You always have to be looking at residents' skin. You want to make sure it's not getting dried out. You want to make sure that they don't have reddened areas all over the body. And sometimes it's real upsetting to me after I've been off for a few days and I come back and the resident has red skin either around their elbows, in their buttocks area, or just any place, and no one's even mentioned it to me.
Let's talk about some of the problems we might encounter with skin care. Here you can note something known as excoriation. Now this can happen around the buttocks area, particularly if the resident is sitting in urine for too long, or even if you're changing the resident very regularly, but the resident has very strong or concentrated urine that can actually burn the skin. A fungal infection can also take place and look very bright red. Here we have a small decubitus ulcer beginning here. If you notice a blackened area on your resident's skin like this, immediately report it to the physician as well. This is something known as eschar. This is an outside covering to a skin problem, and the problem can be much more serious underneath the layers of the skin. Once the eschar is removed, you could have a stage 3 decubitus or even stage 4 underneath that area. Here you can see full thickness all the way through the skin, all the way down into the muscle and fatty layer. We do not want to see any of those serious skin conditions in our resident. For that reason, it's important to monitor closely and report even the slightest change in the color or the integrity of the resident's skin.
Hair. Hair color change is probably one of the most obvious signs of aging. Hair color is caused by a pigment called melanin, produced by hair follicles. With aging, the follicle produces less melanin. Hair becomes progressively lighter, eventually turning white. Body and facial hair also turns gray, but usually later than scalp hair. The hair in the armpit, chest, and pubic area may gray less or not at all. Hair becomes dry because of the decreased production of scalp oils. The hair strands become smaller, so the thick, coarse hair of a young adult eventually becomes thin, fine, light-colored hair. Many hair follicles stop producing new hairs altogether. About a quarter of men begin to show signs of baldness by age 30. About 2/3 of men have significant baldness by age 60. Men may find the hair of their eyebrows, ears, and nose becoming longer and coarser. Some women may find that they have coarser facial hair, especially on the chin and around the lips. Nails. The nails also change with aging. They grow slower and may become dull and brittle. They may become yellowed and opaque. Nails, especially toenails, become hard and thick. Ingrown toenails may be common. Lengthwise ridges may develop in the fingernails and toenails. Care tips help with hair and nails. Maintain good hair hygiene. Brush the resident's hair to stimulate circulation and oil production. Do not trim toenails. Refer the resident to a podiatrist. Some common diseases of the nails include ingrown toenails and fungal or bacterial infections. Summary. You provide assistance and encouragement to residents starting with very basic needs of eating a good diet, maintaining daily activities, keeping good hygiene, and remaining active as they socially interact with others. Even though many changes occur to the physical systems of the body as we age, direct care staff and administrators play an important role to help residents enjoy healthy, happy, and meaningful lives in our communities.
You have reached the end of this lesson. To exit this course, click Exit in the upper right-hand corner.